Ready? Good morning. Welcome to In the Trenches with DAC. Today's topic is pleural effusion. This is not an uncommon problem that we see in patients admitted to the hospital. Fluid within the pleural cavity. The approach is to figure out what the cause is and then treat it. So if you see a pleural effusion, and that's usually diagnosed via chest x-ray, although sometimes CAT scan, the first thing you need to do is make sure that the fluid layers out. Normally you'll take the patient and they'll put them in the decubitus position and see that the fluid layers. If not, if there's going to be a tap, it clearly needs to be done under ultrasound guidance. If it does layer out, then you can either do a bedside thoracentesis or an ultrasound-guided thoracentesis in the radiology department. Okay, when you're doing the thoracentesis, remember to go above the rib. Okay, underneath the rib, you have the neurovascular bundle, and you can have complications. So when you're doing a thoracentesis, do it above the rib. Okay, now the thing with thoracentesis is classification. So basically put into two categories, transidate and exudate. Okay, and the purpose of doing this is to separate these conditions into two boxes. So if it's a transidate, you're going to look for certain conditions, and if it's an exudate, you're going to look for other conditions. An important point is the concept of transidate and exudate is limited to pleural fluid. If you're evaluating a patient with ascites, you're going to look at a SAG. Okay, you're going to have a high SAG greater than 1.1 or equal, and a low SAG less than 1.1. This is for acidic fluid. For pleural fluid, you're going to use transidate or exudate. So with that, the causes of transidative pleural fluid are usually due to abnormal Starling forces, and the most common cause is CHF, but you could also see it with cirrhosis of the liver, and sometimes nephrotic syndrome, Once in a while, you could see it with other causes like atelectasis, which could either cause transidate or exudate, usually more transidate. Pulmonary embolism, which could cause transidate or exudate. If it's a transidate, it's usually due to atelectasis. Sometimes Meigs syndrome, which is a benign ovarian tumor. A benign ovarian tumor associated with ascites or pleural effusions, and that could also be exudative. Now, if you're thinking of exudative pleural effusions, what you're going to think of, number one, parapneumonic effusions, which are due to infection, usually bacterial infections, tuberculosis, malignancy, and connective tissue diseases, especially rheumatoid arthritis and lupus. Okay, other things could do it also, including pancreatitis, pulmonary embolism, sometimes hypothyroidism, and there are a bunch of miscellaneous causes, including medications and sometimes lipid abnormalities that could also do this. I'll talk about that in a little while. With exudate, the main things are parapneumonic, tuberculosis, malignancy, and connective tissue disease. So this is just a little schematic as far as what causes transidates and what causes exudates. Now you need an approach. So you're going to do your pleural tap. You're going to get 4 tubes. Okay, you're going to have your chemistries, cell count, your hematology, your micro, and cytology. These are the 4 tubes. So the most important thing is the chemistry. And with the chemistry, you're going to get a protein, an LDH, and a glucose. And sometimes you're going to get a pH. And even less often, you're going to get an amylase. I'm not even going to put amylase down here. So the protein and the LDH are going to be used to determine whether you have a transudate or exudate. And the criteria that are used are Light's criteria. Okay, so if you have a fluid protein, serum protein, ratio greater than or equal to 0.5, a fluid LDH over serum LDH, ratio greater than or equal to 0.6, or a fluid LDH greater than or equal to 2/3 the normal range in the blood. If you're one of the three, okay, you have an exudate of effusion. That's how you make the diagnosis, and that's the first thing you're going to do. One thing you need to be aware of is the phenomenon of a pseudo-exudate. You have somebody who has heart failure, they have a pleural effusion, and they're diuresed. And the fluid, just like in the blood, is the protein over the fluid content, or the LDH over the fluid content. And these people are volume depleted from the diuretic a little bit. It could falsely elevate the protein or LDH, and that could give you the phenomenon of a pseudo-exudate. Now, another pearl is bilateral pleural effusions. The most common cause is heart failure. That's the most common cause. And that you normally see more fluid on the right than the left. But that's a clue. So that's the protein in LDH. Now, if you have an exudate, the role of the glucose, there are four things that will cause a low glucose in the fluid. So it could be a parapneumonic effusion, it could be infection. Doesn't have to be, but it can be. Malignancy, TB, and the fourth thing is rheumatoid arthritis. That's the connective tissue disorder, disease that causes low glucose. RA, somehow it interferes with the pumping of glucose from the blood into the pleural fluid. These are the four things with an exudative effusion that cause a low glucose. That's the role of that. The role of pH really is just with parapneumonic effusions. So you have somebody with an infection. Okay, they have an infection and they have a pleural effusion rather, and you want to know the severity of the effusion, and you can look at the pH of the fluid. Okay, and you can divide parapneumonic effusions into two categories: benign and complicated. Okay, a complicated pleural effusion, you'd need chest tube drainage and you may need pleural decordectomy. So you might need the thoracic surgeons involved. If the pH is less than 7.1, it's a complicated effusion. Greater than 7.2, it's benign, and somewhere between 7.1 and 7.2, it's in a gray zone. And sometimes it's best to retap it 24 hours later and see what direction you're going into. Now, the amylase in the fluid, you could see with pancreatitis, you could see it with certain malignancies, you could see it with a perforated esophagus. Of course, you know, you're not going to need that to make the diagnosis there. That often is not done. That's the chemistries. Now, cell count with diff. So, if you have increased white cells, the PMNs or lymphocytes. Elevated lymphocytes in the pleural fluid, that's an exudate, you could think of TB or malignancy. And PMNs is more of a parapneumonic effusion. And CT diseases, you can see both PMNs and lymphocytes. What about red blood cells in the fluid? There are really four things you have to think about: trauma, malignancy, TB, And you can see this sometimes with pulmonary infarction due to like a small pulmonary embolism or possibly sickle cell disease. Once in a while you could get that. But these are the things. Trauma, obviously, you're going to see a lot of red cells with trauma and malignancy. Eosinophils, sometimes you'll see them. They could be seen with viral pneumonias, resolving bacterial pneumonias, and with pneumothorax, you could see eosinophils, and sometimes with drug-induced reactions. So that's the cell count with diff. The micro, you're going to send that out, and you're also going to send out AFB studies, especially in somebody you suspect tuberculosis. Now, pleural effusions with TB, they're seen with primary TB, not reactivation. And if left untreated, they just go away on their own. I mean, it will go away, and then at some point in time, the pleural effusion, tuberculosis will come back. But they're usually self-limited. Cytology, obviously, if you're concerned about malignancy, and the more fluid you have, the better yield you're going to get with cytology. Now, there's another situation I want to mention. What happens if you're aspirating pleural fluid and you get milky white fluid? Okay, so you're pulling it out and the fluid's not clear and it's not serous-sanguineous, it's whitish. So there are three things you think of here: pyothorax, chylothorax, and something called chyliform or pseudochylus. We don't see that as much anymore. Chyliform. So a pyothorax is due to pus. It's due to an empyema. And the way you figure that out with the pus, you spin it down and you will get a supernatant. Okay? A chylothorax is triglycerides. So if you see a milky white fluid, you send serum triglyceride level on the fluid, and if it's greater than 110, then you think of chylothorax. Pseudochylus or chyliform is actually due to degenerated cholesterol crystals. We used to see this with long-standing rheumatoid arthritis or tuberculosis. And cholesterol crystals, the mnemonic was chip off the old block. You see like a block and a chip off of it, and those are cholesterol. We don't see that as much anymore, but you should still be aware of it. Okay, some other clinical pearls to wrap this up. I talked to you about CHF bilateral effusion. The mechanism normally of pleural effusions with cirrhosis of the liver is you have ascites and it's seeping through pores in the diaphragm open, and it goes into the chest, more often on the right side of the chest. That's cirrhosis of the liver. With pancreatitis, it's a left-sided pleural effusion. Okay, and obviously there are going to be other signs of pancreatitis. It's not going to be an idiopathic pleural effusion. Those are some isolated facts that I think are important. So in summarizing, pleural effusions we see, if they don't have a history of this, you need to make a diagnosis as to the etiology. You're going to do a diagnostic thoracentesis, and you're going to send off chemistries. Chemistries will help you distinguish a transudate versus an exudate. Remember the phenomenon, a pseudoexudate and CHF. If it's an exudate, a low glucose could narrow it down to certain things. And if it's a parapneumatic effusion, you're going to get a pH to determine whether it's benign versus complicated. The cell count sometimes could give you a clue as to maybe you're dealing with malignancy and TB as opposed to a parapneumatic effusion due to bacterial pneumonia. Micro and AFB is important in certain situations. Cytology is important. Then once you find out the cause of the pleural effusion, you can treat the patient. If it's heart failure, they're going to need more diuresis. cirrhosis, they may need diuretics. Often they have ascites also, so you're going to treat the ascites. If it's cancer, you're going to treat the malignancy. TB, you're going to treat the TB. Connective tissue disease like rheumatoid arthritis, you're going to treat that. So that's my take on pleural effusions. Once again, people, we're in the trenches here.